Good afternoon, everyone. Welcome. My name is Caroline Kuo, and I serve as the Assistant Dean for Diversity and Inclusion at the School of Public Health. Thank you for joining us today. It's so great to see all of you here. So today marks the second event in a four-part series sponsored by the Center for the Study of Race and Ethnicity in America and the School of Public Health, with additional co-sponsorship from the President's Office, from the Warren Alpert Medical School of Office of Diversity and Multicultural Affairs, and also the Office of Institutional Equity and Diversity. So I'd really like to thank the leadership at those respective offices: President Christina Paxton, Dean Joe Diaz, and the Vice President of Institutional Equity and Inclusion, Shante Delalue. They all have been incredible sources of support as we forge new interdisciplinary collaborations across campus. And I think these collaborations are exciting because they allow us to come together and advance scholarship around diversity and inclusion. Our inaugural dean, Dean Fox, sitting here today, and our new dean, Dean Marcus, have also enthusiastically supported this opportunity to bring our nation's leaders around innovations around health equity and to bring conversations to Brown about how we can overcome some major disparities in health. So welcome. In this particular partnership, the School of Public Health has been so fortunate to partner with the dynamic director of the Center for the Study of Race and Ethnicity in America, Tricia Rose, who's also here today. Thanks, Tricia. It's been so great working with you. And her incredible team who are also here. I see them in the back. So I see Christina Downs, Caitlin Scott, and also Stephanie LaRue. And I'd also like to thank our team here at the School of Public Health. In the back, Joel Hernandez, who's really spearheaded this effort, with Laura Joyce and Karen Scanlon. So thank you to all of you. So in this series, we welcome an opportunity to engage with thought leaders and champions of health equity from across our country. Last night, we launched the series with a provoking conversation with Dr. Sherman James. He talked about the pernicious social and structural barriers that we must collectively tackle in order to ensure health for all. And today, we're thrilled to continue this conversation with experts who are dedicated to advancing health equity in their communities and in underserved populations. They will be sharing the innovative approaches they're spearheading to address health equity. And at this historical crossroads, as we're facing monumental shifts in healthcare access in our country, we do need to build innovative approaches that close persistent but avoidable gaps in health equity. So Dr. Aubert has the pleasure of introducing our leaders here with us today in just a minute. But before he does that, I want to invite you all to look forward to the spring series, which is part 2. We'll be welcoming Dr. Mona Atisha to talk about the lead crisis in Michigan on March 1st, followed by another practitioner series later in April. So we hope to see all of you there. So now I welcome Dr. Ron Aubert to the podium. This wonderful series is his brainchild, and we're so happy to have him introduce our speakers.
Thank you, Caroline. Is this your phone?
No.
Oh, okay, leave it here. All right, good. First of all, thank you for coming out. We've had a really tremendous kickoff, and first of all, it's very unusual for us to be able to put together a panel and a speaker this series. These are all our first choices, and I can't tell you how hard that is to pull off. I mean, Caroline could certainly tell you how hard that is to pull off. So we're very, very fortunate today to have all the people that we're going to hear from. My name is Ron Aubert. I'm the Provost Visiting Professor in the Center for the Study of Race and Ethnicity in America and the School of Public Health. So as part of this series, one of the things that I wanted to do was, in talking to Dr. Rose and my colleagues at the School of Public Health, I wanted to get beyond measurement. We've seen a lot of panels and discussions about the measurement of health disparity and health inequality. Wanted to really also focus on practice. What are people doing in public health practice to try and make a more equitable world? And so we're very delighted today to have the 3 people that you will hear from very shortly. Let me just take a moment to give a little bit about who you're going to hear from. So Karen Hartfield will start us off. Karen is a lecturer in the Department of Health Services at the University of Washington. That's her academic affiliation. But she's also the administrator for the HIV/STD program at Public Health in the Seattle and King County Health Department. She has worked in HIV prevention, communicable disease prevention, immunization promotion, asthma prevention, family planning, and public health settings for over 25 years, which is hard to imagine when you see how youthful she looks. She is particularly interested in how local public health departments address racial and ethnic disparities in health outcomes and access to services. It is her belief that health education and communication programs provide opportunities to reach communities and individuals who lack access to information and services. She's a native of Chicago. She holds a Master's of Public Health degree from the University of North Carolina, Chapel Hill. She will be followed by Linda Goler Blount, who is the president and CEO of the Black Women's Health Imperative and has been in that position since 2014. As president and CEO, Ms. Blount oversees the strategic direction for the Imperative and is responsible for moving the organization forward in its mission to achieve health equity, reproductive and social justice for Black women across the lifespan. Before joining the Imperative, Linda served as vice president of programmatic impact for the United Way of Greater Atlanta. She was the first ever national vice president of health disparities at the American Cancer Society. With more than 25 years of experience in public, for-profit, and nonprofit sectors, Linda has a distinguished career that includes successful tenures at the Coca-Cola Company and the U.S. Centers for Disease Control and Prevention, just to give you two very diverse spans of institutions. She also has extensive international experience and has served as a consultant to government ministries in Germany, Barbados, Malawi, Trinidad and Tobago. She is a Michigan native. She holds a master's degree in public health and epidemiology from the University of Michigan. She also has a background in computer science and engineering, so you're going to see some very interesting and impressive people today. Then finally, one of our own, Nicole Alexander Scott. Dr. Nicole Alexander Scott has been the director of the Rhode Island Department of Health since May 2015. Dr. Alexander Scott brings tremendous experience to this position from her work as specialist in infectious diseases for children and adults at hospitals in Rhode Island affiliated with Brown University at the Rhode Island Department of Health. She is board certified in pediatrics, internal medicine, pediatric infectious diseases, and adult infectious diseases. She has a master's degree in public health from Brown University. She is assistant professor of pediatrics and medicine in the Warren Alpert Medical School at Brown University and is assistant professor of health services policy and practice at the Brown University School of Public Health.
Associate professor.
Oh, excuse me, make that change. Don't want to cheat her from her.
It's brand new.
Okay, great, because, anyway. But in her tenure as Director of Public Health, the department's three leading priorities are addressing the social and environmental determinants of health, eliminating health disparities and promoting health equity, and ensuring access to quality health services for all Rhode Islanders, including the state's vulnerable population. So we have a really, really good cast today of people who are really on the front lines of making things happen. So without further ado, one housekeeping matter. After the panel discussion, we hope that you will join us for refreshments, which are going to be in the back. Nod, Caitlin. Okay, great. So at this time, I'd like to turn it over to Karen Hartfield, who will kick off today's panel.
Thank you, Ron. Ron and I have known each other for actually over 30 years, so he's just trying to flatter me with that little line about how young I look. He knows the truth. Thank you so much for inviting me. It's really a privilege. I love talking to public health students and faculty. So I'm going to talk about the opioid crisis. You can't open a newspaper anymore without seeing frightening articles about the opioid crisis. Lots of talk, but what are we going to do about it? And in this headline, you'll see down there, Trump declares public health emergency, and what does that mean? And everybody's still like, I don't know what that means. Doesn't mean money, though. And how is it affecting racial and ethnic minorities? I'm going to review some barriers to reducing opioid use and also King County's innovative approaches to the problem, some of which you may have been reading about in the newspaper lately. So just to give you a little bit of background, nationally deaths involving heroin and synthetic opioids quadrupled between 2010 and 2015, to the point now where overdose is actually the leading cause of injury-related death for 25 to 65-year-olds nationwide, which is pretty astounding. It's well established that opioid use contributes to other public health and social problems. So while we hear about the results of, overdoses and whatnot, probably equally important is that opioid use is associated with HIV, hepatitis C, other health problems, and then a whole host of social issues, poverty, family disintegration, justice system involvement, and other issues. So Ron particularly wanted me to address this point. How is the opiate crisis connected to racial inequities and health disparities? I would argue that the opioid crisis is an equity crisis, despite the fact that the new face of the opioid user is mostly white. If you look at overdose deaths, you'll see that the rate of deaths is more than twice as high nationally among whites as among blacks and Latinos. And this disproportion has been growing. Heroin use also is higher among non-Hispanic whites. The opioid crisis, as I'm sure you've read, has hit suburban and rural areas particularly hard. Some speculate that the new face of the opioid user is driving all of this attention to the crisis, and you could spend hours discussing that. But I think this masks the very real impact of the crisis on racial and ethnic minorities. Just a couple of examples. Opiate use is connected with justice system involvement. More than 80% of those convicted of heroin trafficking are Black or Latino, though all racial groups buy and sell drugs at roughly the same rates. And if you've read books like The New Jim Crow, you'll be familiar with some of that data. Blacks are arrested for drug crimes at twice the rate of whites. So even though the face that we see in the newspaper is white, the impacts are very, very significant in our community. There are also disparities in access to drug treatment. Racial and ethnic minorities are disproportionately uninsured and underinsured, which makes accessing treatment difficult. So really quickly, I'd like to just look at some of the main drivers of the opioid epidemic. Prescribing practices for highly addictive drugs. This has gotten a lot of press. Most experts believe that overzealous prescribing practices in the early 2000s contributed heavily to the current crisis. Now, since then, new guidelines for prescribing opiates have led to a tighter market for prescription opioids, while heroin is now actually in some cases easier to get than oxycodone. And so it's also less expensive. People who started out addicted to prescription opiates seek heroin and synthetic opioids as a substitute for the prescription drugs they can no longer get, and that really is a new phenomenon. Another driver is fentanyl, which we hear about a lot. We heard about fentanyl killing Prince and other celebrities, and fentanyl basically is an opiate, but it's so strong, it's actually 50 times stronger than heroin, and small amounts of it can lead to death. And in some of the places where the opioid overdose death rate is skyrocketing, it is largely due to fentanyl, particularly in the East Coast and Midwest. Stigma is an issue that's not talked about a lot, but I think it's really important that people remember that using drugs is stigmatized. So people often delay seeking treatment or say, well, I just have a bad back and that's why I'm doing it. The longer people delay getting treatment, of course, the harder it is to get off of it. And in addition, they may have developed other health problems. And then finally, what I call is the very real difficulty of getting one's life back when you're an opioid user. When you think about the daily life of an opiate user, the need to dose several times a day just to avoid feeling extremely ill, sort of like the worst flu that you've ever had, and in order to feel normal, you're going to be using several times a day. So you need to dose, you need to score the drugs, you need to get the money to score the drugs, you need to find a place to use the drugs, especially if you're homeless. You need to have clean supplies in order to avoid bloodborne pathogens. And this cycle gets repeated over and over again in a day. So turning to King County now, just really quickly. King County, Washington is where Seattle is located, so if I interchange those words, forgive me, I live in the city, so I'm a little city-centric. Some of the indicators in Seattle and King County are heroin deaths tripling between 2009 and 2014. Interestingly, though, prescription opioid-related deaths decreased over that same period, suggesting that persons with substance use disorder in our area are switching to heroin. Needle exchange volume has tripled in the last 15 years, and drug treatment admissions for heroin are skyrocketing. And this chart gives you an idea of what it looks like in terms of drug-caused deaths. I think what's interesting here about this graph is that the sharpest trend increase here is methamphetamine and coke. And I think that that's actually sort of unique to West Coast cities. I haven't looked at the data in other cities, but I suspect it's similar. Still, as you can see in 2016, we saw the most drug-caused deaths we've ever had. Oops, is that correct? Okay. These next two slides highlight a couple of opioid-related disparities, though. This slide shows you that although nationally you don't really see this picture, in King County, American Indian Alaska Natives with a very wide confidence interval, but blacks with a much smaller confidence interval are actually overrepresented. The rates of drug-induced deaths are actually higher. So I think in our area, even though we have fewer blacks, Latinos, American Indian, Alaska Natives, we need to focus on the population. Another interesting indicator is naloxone use. So naloxone is also called Narcan, and that's the drug that reverses overdoses. And you come back to life. It's kind of a miracle. So we distribute Narcan kits to our needle exchange customers, and I took a look at some of our survey data for the last 3 survey cycles, which is actually over a 6-year period. And what I discovered there is that African Americans are much less likely to have a naloxone kit. And that's a very troubling trend, because clearly if people are injecting and they're in a pair and someone has a naloxone kit, then they can hopefully reduce their overdose. Okay, this is interesting. Actually, when I took a picture of this headline, I thought, oh, these are all public health headlines. King County, I just want to mention, is like a tale of 2 unequal cities. I don't know if anyone is from that area here. But on one hand, King County is reaping the benefits of the economic boom associated with companies like Microsoft and Amazon. We have the hottest housing market in the whole country. The median home price in Seattle is $700,000. It's doubled in the last 5 years. And with that, the concentration of high-paying technology jobs has led to massive income inequality in our area, housing unaffordability, and migration out of urban areas into suburban areas that are lower income and have less access to services. So when you look at overall indicators for Seattle and King County, it looks like the healthiest place in the world. But when you look hard, you will see the inequities there. So from how long will you live, it might depend on your neighborhood. That's a Kaiser study that demonstrated that people in wealthier areas in King County live 14 to 18 years longer than those in poor areas. Homelessness, which is clearly driven by our housing unaffordability, is at an all-time high. And we know from our surveys that 80% of our needle exchange clients are homeless. So you can kind of put 2 and 2 together there. This slide shows you a little bit about African Americans in King County. And all those green areas are where African Americans are living. Previously, when the city was more affordable, people lived more in the central core. So if you were to superimpose this map on other maps about cardiovascular disease, obesity, and whatnot, you would see that the green areas are poor and have worse health indicators. I won't go into detail on this slide, but since you're public health students, I thought you'd be interested in looking at the upstream, downstream analogy. Have you all heard of that? Yeah, okay, and I'm not going to go into it too much. But King County, I would say, is very, very committed at looking at upstream factors that lead to conditions that lead to poor outcomes. And so when we develop programs, we always try to look at upstream factors that are contributing to what is on the bottom there, the unhealthy stream. Okay, so how many of you have heard that Seattle is developing safe consumption sites? Just a few, okay. Well, on a recent trip to the other Washington, the hotel concierge asked me where I was from, and I said Seattle, and she said, oh, that's where it rains all the time, right? And everyone works at Amazon, and you're going to be giving out heroin and letting people shoot up inside. And it was like, kind of, sort of. It is true that we are working hard to establish what is commonly known as a safe injection site and getting closer by the day. First of all, what is this intervention all about? It's clearly an intervention that's designed to reduce the negative impacts of the opiate crisis. In King County, we're choosing to call them Community Health Engagement Locations, or CHELs, and that's very, very deliberate. We're not calling them safe consumption or safe injection sites, because what we feel is that this service needs to be a wraparound service, and we need to reduce stigma, which is associated with using words like safe consumption, safe injection. So there are no CHELs, or safe consumption sites, in the United States at the moment, but they are widely spread throughout Canada and Europe. So a CHEL is a harm reduction approach, first and foremost. It is harm reduction. It is not a panacea or a cure. It provides multiple services for persons with substance use disorder that they need to stabilize their lives. At its core is providing a space where injection drug users can inject indoors under the supervision of a licensed healthcare professional. But we believe we need to provide other services at the CHEL. Supervised injection, naloxone, syringe exchange, rapid linkage to drug treatment if it's not on site, behavioral counseling, and rapid linkage to primary care, particularly for wounds and abscesses. If we had all the money that we would like to have, we would also provide housing assistance, because as you can see, that's really an issue, and legal assistance. But the vision for the CHEL is keeping people alive today so they're ready for treatment tomorrow, next week, or next month, or maybe never. Some of the opponents of safe injection sites say, well, you just need to put all the money into treatment. And any of you have worked with substance users will know that not everyone is ready for treatment, wants treatment, or feels that they can access it. So this intervention is really about keeping people alive and engaged in services. Ron, can you give me a time check? Keep going? Okay. So King County, this is just a little graphic that we use to try to explain to people that King County CHELs will have a positive impact on both individuals and communities. So I already told you what the primary goals were for individuals, but the community is also going to benefit from having CHELs, because there will be a reduction in public injecting discarded needles on the street, which is a very big issue in Seattle and in King County. And reduce crime. And there are data that actually back up that having a safe injection site will have positive impacts on the community. And of course, society will benefit from reduced health inequities. So just to give you an example of how it's going to work, we're studying Canadian European models. And the one that we look at the most is Vancouver Insight. We convened a design team to develop an implementation guide that's available on our website if anyone is interested. There's no cookie cutter approach, but I just want to show you a little bit about how Insight works, give you an idea of what we're trying to do. So this is where you walk into Insight, the safe injection site, and this is the waiting area. And one of the things that I learned when I was there is that the waiting area itself needs to be really big, because most of the people coming in are homeless, and they need a place to put shopping carts, they need a place to put their bicycles. In addition, most of them are coming in some form of being drug sick. And so having them all scrunched together in a waiting room is not a good idea for conflict resolution. Basically, Insight provides an organized system for people to move through. The clients register, wait to be called, wash up, and then go to the injection booth. So this is what the supervised consumption room looks like. These are all booths. They look kind of like going to the hairdresser. You know, there are mirrors, and it's very clean and nice. The mirrors are there so that the injector can find a good vein, and also so the nurse can see what's going on, because if there are 12 people in there and one nurse, it's a little bit hard to keep track of what's going on. One common myth is that people are allowed to share drugs. We don't, Insight in Seattle will not allow people to share drugs, sell drugs, or help each other inject. After people inject, they're strongly encouraged to move into what's called a chill space, where they can further be monitored and recover and then go back out on the street. So what we're hoping in Seattle is to develop something similar. Okay. I'd like to highlight a few challenges associated with CHEL startup and reflect on issues specific to African Americans. As you can imagine, there's a whole host of challenges, and again, that is a topic for a whole seminar, but probably the biggest challenge is siting and community impact. It's absolutely critical to place the CHEL in an area with a concentration of injection drug users, and also looking at our surveillance data to find an area that has a high rate of overdose deaths. In King County, as you might guess, that's the downtown Seattle area. And with the slide I showed you about how amazing and rich Seattle is, you can imagine that business associations are very opposed to adding this service in the middle of the thriving condo market. So we're facing major challenges with where to put the safe injection site. The other issue is legal challenges, and we don't know exactly where this is going, although we just managed to get a positive decision on one. But the federal government, of course, criminalizes drug possession, but also maintaining a drug-involved premise, if people are familiar with something that's commonly called the crack house statute. Basically, if the federal government decided to, they could come and seize the building that the CHEL is in. And so, as you can imagine, landlords are not super excited about having us come and rent their space. We came very close to finding a space, and then the landlord pulled out. We think, though, that there is a precedent in the state of Washington for the local Board of Health to have broad ability to preserve the life and health of people within the jurisdiction. In addition, there is a precedent set that with needle exchange, a legal decision in Washington gave the health officer the ability to implement a needle exchange despite illegal distribution of paraphernalia. Some people feel like the safe injection site movement is like the needle exchange movement. I don't actually think that's true, but I think that it is true that there is a precedent for doing something that is illegal at the federal level. Finally, I want to reflect on these issues with specific focus on the African American community. We have to make sure the intervention is acceptable to the community. There could be a lot of reasons why supervised injection is met with skepticism in the community. This graphic here is from a newspaper article in the Black Community newspaper, which basically says that people think it's fine, but I have heard otherwise. So the issues I would bring to the fore are the experimental nature of this intervention could invoke the legacy of Tuskegee, and I think we have to be really, really cognizant of that. Secondly, will the CHEL help our community get rid of the consequences of substance use, but also the legal and societal consequences? Some people feel like, well, if you're sort of condoning drug use or making a place for people to use, and we'll have more people in prison, and we'll have all of the consequences that fall from that. Does the CHEL inadvertently condone drug use in a community that's already ravaged by the effects of substance use? Could a CHEL exacerbate the disproportionate impact of incarceration on African Americans? And from that needle exchange survey I talked about, there actually are data that show that African Americans are less likely to plan to use CHELs regularly than are Latinos and whites. So these are all questions that I feel we have to really address. I'm going to skip over my other intervention, which is about walk-in access to buprenorphine, medication-assisted treatment. We might have time for that in the questions. And I just want to close by showing you some street art that I saw in Vancouver when I was visiting Insight. And I think this really kind of sums up why we're doing this intervention. Thank you.
Thank you so much, Karen. Now we'll have Linda Blount, President and CEO of the Black Women's Health Imperative.
Well, good afternoon. I'm going to attempt to set a timer, but if it, okay. If it gets out of control, just let me know. Okay. Well, as Ron said, I'm the president and CEO of the Black Women's Health Imperative in DC, and I'm really happy to be here to have a conversation about, kind of about what we do and offer my thoughts on health equity, and I think I probably come at it from a slightly different perspective. But I'll start with my very first experience with racism. I was in 4th grade. I had integrated the elementary school, and we had a band, and I wanted to play the clarinet. So, you know, you try out different instruments, and as it happened, the band director wrote on my sheet, "Thick lips, recommend trombone." And so I saw that, but then my friends saw it at the same time I saw it, and I was just devastated, you know, because I interpreted it as I wasn't good enough to play the clarinet. But I stuck with it. I persisted, as Sherman James said, and went on to play clarinet right through college. And as Ron said, I did go to the University of Michigan and studied epidemiology, and I used to hang out at that place. And I heard that Brown's got a football team. Sorry. Oh, come on. Sort of. I didn't say it. So, 35 years ago, Billie Avery founded the Black Women's Health Imperative. She got a MacArthur Genius Grant and brought 2,000 of her closest friends together to Spelman's campus to talk about self-care and how Black women should take care of themselves and take care of each other. And so for 35 years, that's really sort of been our focus. And now we kind of organized this way. Wellness, we've got an CDC grant for diabetes prevention, which we've expanded to just chronic disease prevention. Do a lot of research, I'll talk a little bit about that. Reproductive justice is huge, HIV prevention. I don't have to tell you all the statistics. And then our policy focus is around enrolling women in health insurance and clinical research participation, but also looking at preventive services, particularly the essential health benefits, and maintaining HBCU funding. So after 50 years, here we are. So in 1962, Gloria Richardson started the Cambridge movement in Cambridge, Maryland. She was the first woman to lead a civil rights movement. And this was, 2 years ago. So we still have that same kind of imagery. So what is it that we actually know about Black women? And I'll start with what we call the negative narrative. And you've seen these kinds of images. Black women are considered hypersexual. There are plenty of studies that look at medical school students, and particularly around prescriptions of Truvada. And they're less likely to prescribe Truvada to Black women because they think they're going to engage in riskier sexual behavior. Black women are angry. You know, I've been called the angry Black women, probably some of you have. As my friends say, there's nothing worse than a smart Black woman with an opinion. Black women are attitudinal. We've been certainly called that. And then manipulated. You know, this had Black Twitter abuzz last week with this model's hair and what the perspectives on what did and did not happen with her hair. But of course, you remember the Dove commercials and the Pepsi commercial. And so you always sort of wonder who was in the room when the ad agency said, this would be a great idea. Yeah. And then there's the science narrative. These are the statistics that we hear all the time. We're overweight, we're obese. 50% of the incoming freshman class at Spelman is pre-hypertensive or pre-diabetic, and about half of them are overweight or obese. We know the mortality rates around breast cancer differences. We get breast cancer younger. We get a more aggressive form of breast cancer. Breast cancer incidences are actually increasing among Black women. So you kind of wonder then, with the U.S. Preventive Services Task Force, the American Cancer Society, recommending raising the age of screening mammography to 50 and 45, why that would happen. They were using studies that took place in Canada and Sweden where there were no Black women. And of course, my colleagues say, well, what difference does it make? That's genetics. There's only 4% difference between us all. But clearly something's happening. And so why would you raise the age of screening mammography to 50 if 18% of breast cancers in Black women occur under the age of 50? And Black women have more cortisol in their bloodstreams at any given point in time. And cortisol, as we know, triggers the inflammatory response, raises our risk for a whole host of metabolic disorders. And depending on who you read, Tanae Lewis, Fleta Jackson, David Williams, there are very real physical consequences to elevated and chronic stress. And we'll talk a little bit about that. And then there's everything else. All these other things that we talk about and you all study and the physicians treat. And so the question is sort of what is behind all of this? You know, I'm trained to report on statistics, and I can do that really well. But then the question is that it? Is that all we do? Do we just name it and describe it? And obviously we've been at interventions for a long time. The first report on minority health in 1985. So 30 years ago, but things are in many instances worse now than they were then. So I just want to talk a little bit about sort of perception and practice. When I first started at the Black Women's Health Imperative, we did a study and we asked Black women to define health. Purely qualitative, we just said, give us words and phrases, whatever health means to you. 80 to 85% of the words and phrases that Black women use, and we're up to about 3,800 respondents now, were psychosocial. I'm at peace, I'm calm, I'm in control. About 10% of the words and phrases Black women use to define health were financial. I can keep a roof over my head, I can take care of my children, I can pay my bills. Only about 5% of the words that Black women used to define health had anything to do with disease state or physical health. So that suggested to me that maybe the way we've been going about this is backwards, because we treat in community-based programs, in the exam room, in research, as if preventing diabetes was really the most important thing. And while it is important, it's not the most important thing. So we decided to take an asset-based approach. Instead of talking about what's wrong with Black women, why not come at their health, at messaging, at imagery, from a position of asset, of strength, of positivity? Because we keep sending Black women a message every time we report these statistics that something's wrong with you. And that's really not what we're trying to communicate. And so we have to focus on, at my shop, and what we're trying to encourage the organizations we invest in, to incorporate the lived experiences of Black women in their work. So it could be bench science, it could be community research, programs, policy. You know, we have a tendency to separate the people that we're focused on from all the environmental impacts. And if we don't start looking at how people actually live, then my fear is 30 years from now we'll be having the same conversation. And so what we engaged in last year was a little bit of social listening. Because Black women are talking about what they think and feel and believe and do about their health. So we looked at Twitter and Facebook data to just kind of get a sense of what was important to Black women. And from October to December of last year, we looked at what women were saying. And no disease made it to the top 10 list, not one. It was psychosocial, it was stressors, it was job-related stuff, economic stuff. There wasn't a single disease in any of the top 10 issues on Twitter and Facebook. Okay. So we thought this maybe is an opportunity to kind of rewind. And so we asked the researchers at Boston University, the authors of the Black Women's Health Study, to go back and look at the data and study women who reported their health as very good or excellent. As it turned out, over 50% of the women in the study, so you're talking 60,000 women, and I think the study is in its 23rd year now, report their health as very good or excellent. So we wrote this report to talk about what they do, how do they live, what are the things that are important to them, are there some regional differences, what is it that we can actually learn from healthy Black women that we can employ in our work. And I've got a few copies of this here. It's on our website, bwhi.org, you can download it. But there's some implications for all of these issues, whether you're developing programs or employee wellness programs, policy, future research, just by studying what women are saying about what they do that keeps them healthy or what their lives are like. So for our shop for the next couple of years, we're focused on a legislative agenda for Black women's health. One has never been done. You would think so, but we're going to produce the first legislative agenda. We're heavily engaged in some data science work. And what we've done, we're going to look at Google data next. So I read Everybody Lies earlier this year and just sort of had this epiphany. I don't know, if you haven't read it, you should definitely read it. It's interesting. But on Google, women have questions. They have problems they're trying to solve, like we all do. We want to know something. So if we can look at Google data and figure out what it is about our health that is a question, is a problem, what kind of answers are we seeking, then we can work with, we've got a team of computing, data science, behavioral economists, mindfulness folks, psychologists, epidemiologists, this interdisciplinary team to create predictive behavior profiles. Because in public health, we try to get people to go from here to here when it comes to behavior change. But really, we need to get people to go from here to here to here, because this never happens. So we're going to create predictive behavioral profiles and develop the programs, the messaging, services, products that we can give to our community organizations we invest in, give to corporations, or maybe sell to corporations, make available to policymakers, so that that work that's coming from Black women themselves can actually inform what we do and how we engage them. And then we're aggressively involved in untailoring. So we probably get a call a month from an organization, very well intended, who's got an outreach program. Right now it's ACA. And they say, we've got this great messaging and imagery in this campaign. Could you tailor this for Black women? And my answer is always no. If you didn't design it with Black women in mind in the first place, changing a picture isn't really going to make any difference. So we actually, for the index, you'll see the pictures of the women. We had a photo shoot, and we asked women, we just put it out on social media, come camera ready. We took pictures. Every picture in that index is from women from the Washington, D.C. area. I am so tired of stock photograph. I don't know what to do. So we're going to be our own photo agency. But we're also very much involved in clinical trials work. We get calls also from pharmaceutical companies, researchers. Could you give us 50 women for our trial? And again, the answer is always no. What I say is, can we talk about why you're calling us in the first place to find the 50 women for your trial? And so far, nobody's been willing to engage in that conversation. Yeah, I'm hopeful. I'm persisting, as Sherman says. I'm steadfast in my reluctance to and refusal to go along with that. But we've got to create a new evidence base for how we engage. We talk about social determinants of health all the time as though they sit in this box over here, and that's not where they are at all. So just a couple looks at some of our materials that we developed. So this is around HIV prevention. The DC government had its own campaign that had Black men lying on the ground and Black women standing over them, pointing at them menacingly or pulling them by their tie. And I said, that doesn't resonate with us. And I was talking to the woman I was talking to the woman from the ad agency, and she gave me the classic line, of course, which was, well, I talked to 2 Black women, and they said they liked it. Okay. So about a year after we launched this campaign, the person who was running HIV for the DC Health Department pulled me aside and said, can we use your materials, please? Sure, no problem. And then this was one of the pieces for the ACA enrollment that's happening right now. So again, we were given materials, and we said, sure, we'll use yours, but we'll use ours. So 2 weeks ago when this rolled out, this one, which within 3 days got shared 500,000 times. The one we were given by the ad agency got shared 3 times. So I would say to, for all of you, obviously we're talking about people here. And my assumption is the people that you focus on, the people I focus on, are not crazy. We do things for a reason. As we said, we do what we value. So we're trying to get people and the women we serve to value changing whatever it is they need to change to be healthy and make that a better cost equation than not doing it. See, I'm close. So if I don't know how to turn it off. Oh, that's, okay, who knows? Hopefully it won't do it again. I don't know how to operate the phone. But it's a cost-benefit equation. So how do we get doing the things that we need to do to be healthy to be as valuable or more than not? So I would encourage you, as you're talking, as you're writing, you're doing your research, think about that. People they're not insane. And then we do things that make sense for where we are right at the moment. Keep those people in mind. And, as we say, our work is difficult, not impossible, but when it feels impossible, we got Auntie Maxine. And if we don't have Auntie Maxine, we always have our attitude. So, if you ever come to Washington, D.C., stop by my office. I put Gloria Richardson on my office wall because I wanted to make sure that not only I and the staff, but anybody who comes to visit us is reminded of why we are coming into work every day, why we do what we do. Because this fight is still going on. So, as Sherman says, we will continue to persist so that 30 years from now, we're not still having this conversation. Thank you.
Thank you, Linda. This persistence thing keeps coming up. For you guys that missed the talk last night, see, it was a real doozy. So next we have Dr. Nicole Alexander Scott, Brown's own. And so without further ado, final speaker, and then we'll move into the question and answer session. Thank you, Dr. Scott. Thank you.
Such an honor to be here and associated with such distinguished panel of colleagues and having learned so much. So thank you. And thank you for the invitation, Dr. Rose and Ron as well. Also an honor, I think, the fact that you had all of your initial invites immediately say yes. Certainly is a reflection of who was asking as well. So thank you. Being able to share quickly, to touch into what Ron mentioned about practice, public health practice, and how we can put this into practice is some of what I want to share briefly today. The first few slides gives us some purpose and reason for why at the Department of Health and on behalf of the state, we say we're doing what we're doing. This highlights how much the US spends on healthcare. That is certainly an outlier. It also highlights the lack of return on investment compared to others, some of whom spend half as much but are living longer. I often say, for those that have heard this, that unless we are living to 125 years of age compared to other countries, there's a problem with how much we're spending on health care. This is a companion slide that also offers some additional approaches. We also see the same developed countries, many of whom have the higher life expectancy, but have to really also highlight the difference. Here is the US, and the blue part of the bar is how much we spend on healthcare costs. And similar to the previous slide, it's the highest blue bar on this. The red part of the bar highlights how much we invest in social services. Social services can fulfill the concept of the socioeconomic and environmental determinants of health that we talk about, what goes on in the community. And we have to, as we engage in conversations about decreasing healthcare costs, we have to together raise our voices and bring awareness to it's not just decreasing costs, but it's also adjusting the ratio of spending to get the better outcomes that we know are necessary. And this nails it home with highlighting the different elements that contribute to someone being healthy. What leads to someone's health outcomes? Clinical care, which is where the blue part of this bar goes to. There's 75% investment that goes into 10% of what determines someone's health outcomes. I'm glad that this is a slide that has genetics as just 10%. Other graphics have it larger, and I believe that it's this or smaller. And the brunt of it, 80%, is physical environment, social and economic factors, both of which also determine health behaviors. And we have to acknowledge that. So that's the basis for which the Department of Health has the 3 leading priorities that Ron mentioned. Being able to make sure that we are deliberate about addressing social, economic, and environmental determinants of health. I'm going to share a little bit more about the second leading priority, eliminating disparities of health and promoting health equity. I consider them as being flip sides to the same coin. We have to expose the problems, talk about them, make them clear. When we highlight disparities of health that exist, racial and ethnic disparities are prominent. They're real, unfortunately. We have to be clear about that. We have to talk also about the structural factors that contribute to that as well. Societally, systemically, racism, sexism, so many of the other isms that exist. But while we talk about the problems, we also have to put forth solutions and take action on those solutions. Promoting health equity means that regardless of the zip code you're from, you should have the right to live the healthiest life you can live in the healthiest community you can live in. We heard earlier about Kings County and Seattle and the differences in life expectancy outcomes by the zip code. And then doing these two helps us ensure access to quality health services. We're deliberate about not just saying health care services so that it's clear. The expanded understanding of health means what goes on in that healthcare setting, plus all of those socioeconomic and environmental conditions that go on in the communities that we know make the difference. And then also doing it for our vulnerable populations. That means those that may not have the voice to be able to advocate for themselves. It could be the very young, the very old, those who are foreign-born, those who may not be able to read or write, those who may be uninsured or underinsured, incarcerated. It came to mind when Karen was presenting on the racial ethnic disparities that exist within the opioid epidemic. We often don't speak of our sickle cell community that is disproportionately impacted by all of the opioid prescribing limitation. They were already not being appropriately treated for their pain. What does the sickle cell community do now? That's a vulnerable population that we need to be able to advocate for. What we did was purposely take our purposely broad 3 leading priorities and focused them into 5 strategies, which are still broad, but have some direction that really look at promoting healthy living. It looks at environmental elements, also promoting a comprehensive health system, knowing that that includes an oral health system, a behavioral health system, and our physical health system. And we can all think of someone that has had challenges navigating, accessing, or affording something in one of those 3 health systems. Also doing what public health is often known for and addressing health hazards and emergent threats, while recognizing that an emergent threat absolutely can include the overdose epidemic that we're in. And then taking what public health does well, which is analyze data, but communicating it to drive action and to improve someone's health. And then what we've done, and this is also online, is associated each of those 5 strategies with 23 population health goals that align with Healthy People 2020 goals, our SMART objectives, and give us something to move forward with and target. And as a department, we've taken those 3 leading priorities, 5 strategies, and population health goals, and then on a monthly basis, we look at metrics and lead measures to see what are we doing as programs and as individuals within the department, as well as supporting the community in helping us to reach those 3 leading priorities. And this is just a snapshot of the great team of folks within the department that range from our Division of Policy, Information, and Communications, that includes our state medical examiners, and then also our Division of Customer Services that includes vital records, and our health facilities and health professionals oversight. I show this because we need to start within the department and help our staff that are overseeing licensing and those that are in the laboratory understand how what they do can and does contribute to addressing socioeconomic and environmental determinants of health. If the laboratory isn't testing for lead, we're not able to see the disparities that exist in communities that don't have their lead testing done as well. So that just is to briefly show a snapshot of how we as a department should be held accountable to applying public health practice. And then here are 2 ways that we're taking that foundation to advance statewide and hopefully nationally health equity and health system transformation. As I said, I would expand a little bit more in that middle leading priority. These are our approaches at expanding the red part of the bar and decreasing the blue part of the bar as we shift investments from healthcare into the community where we know we will have the greatest impact. So a place-based strategy that we have in Rhode Island is a health equity zones initiative. It was the result of years and years of leaders at the department, such as Dr. Peter Simon and so many colleagues, who recognized that we were getting funding from our federal partners at CDC and elsewhere, and giving it to communities, those impacted, in the silos we were asked to give it to them. Prevention for diabetes, prevention for cancer, prevention for asthma, prevention for others. And we noticed 2 things in doing that over the years. One, the people on the other end of each of those silos were the same people, and they weren't breaking themselves up into silos. And number 2, those same people weren't getting any better. We were not seeing the improvements. We were just continuing to funnel money into those communities. So we're taking years, even up to a decade, of working with our federal partners, doing pilots, working with the communities. We have, we were able to convince, and since 2015, have now had 10 health equity zones throughout Rhode Island. And what we have done is taken funding from federal partners and as much flexible funding as we could find to braid that funding and be able to give it to the community in a unified way to drive collective action with authentic community engagement. What it required was for a community to define for themselves what a health equity zone was. It needed to be a geographic area that had a population of at least 5,000 and known socioeconomic and environmental conditions that they wanted to be improved. And the sizes could range, and they do for us. We have a health equity zone in every county in Rhode Island. There are about 5 counties. There's one that's the size of a neighborhood. It's not the size, but it is a neighborhood, the health equity zone. There's an Olneyville health equity zone, and then there's one that's a county, South County health equity zone. And what we required for each zone is to form a community collaborative that built on the assets of that community. So it had to bring together the residents of the community, businesses, municipal leaders, transportation and community plannings, health planners, health system, the education system, law enforcement, and so many more. Some of the collaboratives range in size from 20 to 30 to 50 to 60 that come together. And they had to have a backbone agency that interfaces directly with us at the department on behalf of that health equity zone and those collaboratives. To start with developing a community-led health needs assessment that not only included health care, but the needs of that community, and then action plans that are specific, that are smart, with objectives and measures of how they're moving towards it. Here are some examples of the variety of elements and conditions that people included within their health equity zone. And even further, to show some of the specific examples. The backbone agencies varied across each of the health equity zones. They continue to vary, not in past tense. This one of the Providence ones, the backbone agency, is the mayor's office. They have a Healthy Communities office, and their focus is on tobacco-free environments, access to healthy food and beverages, and access to physical activity and safe walking. Woonsocket, in the northern part of Rhode Island, has their federally qualified health center, Thunder Mist Health Associates, as the backbone agency, and their focus is on substance abuse, trauma, and teen pregnancy. And then we have the Health Equity Zone, that's 2 cities combined, of Pawtucket and Central Falls, with LISC as their backbone agency, and a number of key initiatives that they're working on. And our goal is twofold. One, that we're able to return to our federal partners and those that invest to say, not only have we addressed the diabetes, the cancer, the asthma, and those that they wanted focused on, but we've also tackled the social, economic, and environmental conditions that we know directly contribute to those outcomes. So if you go to our website, you can find out more about the health equity zones, and let's see if I can show a brief video, be able to capture it a little further. Equity Zones initiative. It's a place-based initiative that gets the community to come together as a collaborative, involving partners that never worked together before, whether it was law enforcement and a community-based organization, school administrations, our health systems, businesses, residents, come together, understand what the challenges are in that community, and with seed money from us, be able to dedicate their actions to addressing the comprehensive needs of that community.
Health and the opportunity for good health is not yet in everyone's reach. This means that some people live sicker and die younger than their neighbors. That doesn't have to happen. Good health comes from more than genes and how people take care of themselves. Where and how people live plays a big role. Access to fresh, healthy food, transportation and mobility, safe places to live and play, and economic opportunity all really matter.
We've also addressed those social and environmental factors that we know directly impact them. We've made it so that people can have better access to fruits and vegetables, or that there's safe streets or complete streets so that there's easier accessibility and transportation. There's improvement in the housing in that neighborhood and community, and more job opportunities in that community, all of which we know up to 80% actually determines someone's health outcomes.
Creating these conditions for good health takes collective effort. It takes an entire community working together. Rhode Island's Health Equity Zone initiative provides opportunities for communities to lead these efforts by supporting strong community infrastructure to address the determinants of health locally. These communities are transforming where and how people live by focusing on the things that impact health and economic success, such as access to healthy foods through local community gardens, financial management training, career development, the creation of green spaces, and transportation planning programs. By approaching community development in partnership with the residents and leaders of these health equity zones, we are building healthier, more equitable, and resilient communities.
I love to see empowered communities everywhere being able to raise their voice and use it from a platform that the health equity zones helped establish to make sure that they called for, demanded, and received the services that they know they need and that they have access to, and can hold policymakers, administrators in their community, public health officials accountable to providing that and supporting that community and doing it. But it's community driven. That's what the vision is for me. So I am going to stop there and acknowledge that and appreciate that the Health Equity Zone saw this and said, we want even more of us represented in this and to really advocate for this. These types of initiatives are what we want to really build the communities and make sure that things like gentrification and others, as we work towards these improvements, don't lead to relocation or removal, but there's a voice that's maintained. So I'll finish with saying I'm grateful to have the honor to work with my colleague in Washington as being president-elect of the Association of State and Territorial Health Officials, and he's president currently. The goal will be during this time to bring attention to building healthy communities and resilience, and demonstrating how these types of place-based strategies are what's going to be needed to put public health practice into action at the community level. So, thank you.
Please come to the stage. All three of our speakers were right on time. That's great. That's a little unusual as well. So we're going to have a round of Q&A. I'm going to start with the first couple questions and I'll open it up. I don't want to spend too much time taking away from the opportunity for you to engage our panel. There's a couple. I'm just going to, there's so many things that I could, okay, I'm going to calm down and just try and keep it a little bit focused. So one thing I wanted to tackle first, I know, Linda, one of the things you said rose to the top of the surveys, and you talked when Black women talked about health, was financial stability. And then, Nicole, you also talked about you have financial training as part of the services that you guys provide. I want maybe two of you talk a little bit about that. One, the importance of how you see, Linda, the link between just financial or knowledge, really, and health. And then I want you to follow up, Nicole, with what's actually happening as part of your activities around financial training, what that means.
Sure. I don't know if this is on. So what we got from the surveys is, I mean, we all understand the importance of having money in health. I mean, that's been talked about a lot. But what we, from the social listening analysis, what we got was at the heart of it was control. What women were saying is, if I have money, I can make decisions for myself, for my family, for the people I care about. I can navigate this world more predictably. So it really was about control. There are a lot of financial literacy programs out there, and we've been asked to partner with some. But, you know, and you need to know how to manage your money, obviously. But if you don't have any, if you don't have a sense, if you don't feel as though you have a sense of agency, then a financial literacy program is probably not going to be all that helpful to you. So part of what we're doing with this ACA enrollment campaign is not only saying, yes, you should enroll in health insurance, but here's what it is, here's why it's important, and here's how you use it, so that we can hopefully get the women that we serve to understand that they do have some control, they can make some decisions, they do have agency about their health and the health of their families. And you know, that goes back to mental health, you know, emotional wellness, because if people don't feel as though they can have any control, then again, they're going to do whatever it is they think they need to do to try to have some semblance of it. And we want those activities to be healthy activities and health promoting activities, and not the more self-defeating activities that we see.
And one of the most important elements for us, as I mentioned, expanding the understanding of health, is to make sure that it's clear that economic stability, employment opportunities, economic development and stimulation are critical elements of health. And making sure that the community understood that, the investments that were necessary, and would also have the skills to be able to lead that and drive it from their perspective. So the financial assistance element is to be able to work one-on-one with someone in their individual situations so that they get the tools for being able to navigate in those specific situations. But we also have, like, the Pawtucket Central Falls Health Equity Zone has partnered with the Central Falls Community Development Corporation to be able to look at housing and health system investment within that community, and everyone recognizes that that's a critical element of health.
That's great. Karen, very quickly, and this is really for all of you guys, but we'll start with Karen. You talked about, you showed the headline of this national emergency. you made the quick comment of it doesn't mean any money. And so I want you to sort of address that, and then how is King County and the state even sort of bracing itself for what may be a sort of reduction in funding for across the board for health departments?
Right. Well, fortunately, in King County and the state of Washington, there's pretty generous state funding, and we have a really generous Medicaid expansion program. So the real scary thing is what's going to happen if the Affordable Care Act falls apart, because that's funding a lot of our treatment. And the fact that the Trump administration, got all excited about the national emergency but didn't talk about money, I think is really, really indicative of this whole problem. So what are we doing to prepare? We're trying to get as many outside grants as we can get, and we're trying to come up with new treatment modalities that are a little bit less expensive and better for the population, such as the buprenorphine on demand, where an injection drug user can just walk in, essentially be induced by a public health nurse, which reduces the physician time, and then stay in the program and be followed more like by case managers. So it's a pretty scary, precarious time. Yeah.
Nicole, as a state health director, how are you all preparing, or are you, what strategies are you trying to put in place to try to navigate these unknown waters we're in right now?
Well, similar to what Karen said, the department staff have heard me say that we need to continue to look at ways of diversifying our funding portfolio. The other that's an interesting element in the midst of the challenges that exist is figuring out how to lead and keep your department and colleagues focused on the prize in the midst of uncertainty, questionable leadership, and funding threats at every level. So it certainly inspires me to see the commitment of the staff and the communities that we're serving to move forward in spite of. But it's made me feel very strongly about the fact that civic engagement is a public health issue. And so to every extent that we can continue to keep that at the forefront and make sure that people have a voice, and use that voice at every level is beyond critical.
So, Linda, how much is your organization and other nonprofits dependent on federal funding versus other sources? And again, how does some of this uncertainty impact your organization?
Yeah, so we are a lot less dependent on federal funding than we were 4 years ago, and that's by design. We're still about 40% federally funded. I'd like to get that to about 25%, because while the government certainly has a role, so does the broader community. And if we're really going to, I think, address successfully these health disparities issues, corporations need to have a skin in the game. Obviously, foundations do, individuals do. So we're actually working with some broader corporate partners to try to help them understand that the women we're talking about are largely employed. And
Right.
so it is in their best interest to make sure they're as healthy as possible, and giving them the tools and resources so they know how to go about that. Corporate wellness programs attract a very tiny percentage of employees. So we need to figure out a way to make wellness meaningful to broader employee base, and then get those services to them.
So I'm going to open it up at this point to members in the, Dr. Rose, as Absolutely. Take the first. Take the first question. Gotta get a boss the first question.
This was, whoa, okay, hold it down there. This was amazing. I'm super inspired. It's a little, there's of course, a little sadness in all of the work everyone's trying to do, but this is really not just inspiring, but forcing me to encourage researchers to think a little differently. So I want to ask you about how we might be able to respond to something you all really touched on, which is the importance of taking communities we're serving and their experiences so seriously that we start with where they are and what they know as the answer, and how difficult that is to do, right? That often it's always what we know, whoever the we is, and what ought to happen, because of course their vulnerability is supposed to also mean they don't have any idea what the problems are. So in a room full of researchers to be, et cetera, what would you say to researchers that would be the most important kind of revision to the way we approach research on vulnerable communities, whether it's Black women in particular, whether it's drug users, whether it's poor and people of color in general, and poor whites, et cetera? What can we do in terms of how we approach research that would be most productive to help the extraordinary work you all are doing?
I've got two ideas for you. One is hiring. I think making sure that your qualitative researchers look like the people that you're talking to is really important. And my second one would be compensating people who are giving you their time. I mean, basically, we're privileged to hear from them. And so figuring out a way to budget for incentives or get donations or something like that, which is getting more and more difficult. People don't want to pay people for interviews and focus groups and whatnot. But I believe that if we don't sort of treat our community partners and the community members as equal participants, we're not going to make too much progress.
And I would say, first start with looking at yourselves. As much as we want to believe that science and analysis and the work that we do is empirical and unbiased, it isn't. You all bring everything you have into your science, into the questions you ask, into how you ask them, into who you ask, into how you interpret the data. So, there are ways to be mindful of that. But the other thing is, and I said it in my remarks, the people that you are studying are not crazy. You may not agree with what it is they're doing, but they have a damn good reason for doing it. It makes sense given where they are right now. So start there, rather than start with, you've got to be fixed, and I'm here to do research, participatory, though it may be, to fix you. That's not how they see themselves. So if at all possible, start with trying to see the people you're working with the way they see themselves, and let that drive your questions, let that drive your research, let that drive your analysis.
And I agree fully. I get to chuckle and credit Dean Weddle and taking her community-based participatory research, qualitative research class when I had obtained my MPH. To do that authentically and to do it well takes patience, energy, humility, and to make sure that that is your number one approach in engaging with the communities, and to make sure that your mindset is already clear, that they have the answer. Your job is really to help facilitate them getting there, as opposed to there's a question that you have the answer to that you're bringing to them. I love the example that we have a statewide research grant, clinical trial science award that was awarded. And so we invited the leadership of that grant to come speak to the health equity zones, because they had to do community engagement. And the health equity zones educated them on what their take was. If you're gonna, what are we gonna get for this? How much, you got $1 million, how much of that is coming to us in the community? How much is going to stay? And they had to turn back around and go back. And they're still working and preparing to come back to the health equity zones. I'm helping them along in whatever way you'd like, but they're gonna be the ones that will decide. So continuing to really have that type of approach is critical.
Good for you.
I'm sorry, but I have to ask a metrics. Is that okay if I ask something about metrics? Okay.
Metrics.
So Karen, what was the unit of observation, the geographic unit of observation that you used to look at who, what, where, when, how for the opioid
For
epidemic?
the safe injection.
Yeah. How did you examine? Do you have address data? Where did you get it?
Yes.
How did you
we
map
have
it?
A few different kinds of data. We have, the medical examiner's office is actually part of public health, which is beneficial to us. So we have a lot of data on deaths. But we also have some data now that comes from EMS, or emergency medical services, so we can look at overdoses and where they're taking place. We have data on calls to a recovery line. We have zip code data from our needle exchanges, which are all around the county. So we really looked at all of those things, but
Zip code was the smallest area?
yes, we didn't go
Why is it?
smaller,
Why?
because I think that we were mostly talking to individuals, so we didn't want to get their actual addresses. Yeah, we have a high value in needle exchange around confidentiality. We actually collect no names or addresses or identifying information.
So zip code was the smallest.
Yes, from the medical examiner's office, we could actually go smaller, but I think in terms of the raw numbers, I'm not really sure where that would get us, because we're talking about, roughly 350 deaths a year. Right.
I was intrigued by the theme of strength-based approach and resilience and empowerment that all three of you touched on. And I wondered if you could give us a little bit more insight into why you think that particular approach is so conducive to a health equity focus rather than a health disparity focus, and just give us a little bit more insight in that theme.
I was educated in my previous world as an adult and pediatric infectious disease physician. I was just explaining this yesterday to someone who asked me, do I miss seeing patients? And I said, I do miss my patients very much. The lessons that they taught me in terms of approach to life, especially those with HIV, for whom HIV was the least of their problems. But dealing with, a list of so many others, and I won't get further into the example of that. But that's where I really, just over the course of my medical career is where I really learned about the resilience and that strength and what it can do, and how it's so underestimated and downplayed. If we look at and talk about the different disparities that exist in affluent versus disadvantaged communities, if you took a bunch of the people who grew up in the affluent communities and had the successes that they did and placed them in those disadvantaged communities, you could pretty much guarantee you wouldn't see the level of strength and accomplishment and survival that people have maintained in spite of what their environment is. So just imagine what those people could accomplish being offered or able to have those types of opportunities. That's the driver for me about why we have to look at the strengths, because it just gets overlooked.
And I would say it only made sense. When we survey women, they don't see themselves as broken or broke down. That's not how they view themselves. So why would we approach them that way? If that's not, we'd be completely out of sync. And also, I'm not a behavioral economist. I'm definitely going to come back as one in my next life. But, negative doesn't seem to be as motivating as positive. People want to know they can accomplish something. They want to know they can succeed at something. And telling people, you can't do this, your rates are worse than this, you're never going to be, I mean, that's just not the way to inspire people. And so I think, as my father used to say, you can catch more flies with honey than vinegar. You know, it can't hurt to try it a different way, certainly.
Yeah, I really loved the cover of the report you showed us, that with the healthy Black women in the pictures, and I think that is really important. I know in my work in HIV with men who have sex with men, we've also looked at this sort of risk-based approach versus asset-based approach, and you know, people are saying, well, you know, it's just the opposite, basically. If a risk factor for HIV is having 10 or more sex partners, then an asset-based approach is having not so many sex partners, but it actually may be related more to something like social connectivity, as Linda was pointing out earlier. So I think it's a really important thing to do. It's harder to measure, I think, but it's a really important frame.
Professor Willis with a final question. Oh, yeah, okay. I want to thank you so much for the rich presentations. I learned a ton, and this is one of the best panels that I've been to at Brown, so thank you all. And this is a friendly question, but it's a question of sort of two parts. So briefly, it's about poverty. So we talked about economic stability, work, money, economic opportunity, but the word poverty didn't come up much. And I want to ask about that in two ways. One, is that strategic in terms of what you need to do to kind of stay away from that kind of terminology? And two, how do you think about your work, given the fact that we got, say, 14% of Americans, 50 million people, trapped in conditions which are described as poverty? How do you imagine your work to be able to succeed in spite of that persistent fact? To go back to Brother Sherman James last night. And thank you.
So for answering the first one, it wasn't as if I was avoiding the word poverty, but probably why you heard me not say it, just happened to not say it during this conversation, is that tendency to lean towards, you know, the positive, the flip sides of the coin. We have to expose what it is, but then come up with solutions. Solutions include making sure that people are informed and equipped with what they need to do to build their own employment and economic opportunities, educational and otherwise, as well as the community is equipped to do that. And then for the second question, how to accomplish this in spite of the poverty, for me goes back to the fact that the economic element is a part of health. So I don't see it as one or the other or in spite of, but having solutions for addressing the poverty piece has to be a part of addressing and improving health.
And for me, it's deliberate. In talking to the Black women who were in that survey and reading some of the literature, the majority of poor people believe they cannot be poor at some point, and so they don't want to be reminded that they're poor. So we use euphemism, low resource, whatever. I mean, there's no term that's really great, but particularly if I'm talking to women, I tend not to call them poor because that doesn't resonate, even though they just don't want to be reminded of it. The other point, the way that we can try to deal with this, and are trying to deal with it, is through policy work. We don't deliver services in communities. We're not going to be a financial literacy group, but we can work with lawmakers and do at the federal and state level to try to address some of these structural barriers. But what you're talking about requires an overhaul of our economic system, and if you'd like to come to DC and you can look down the street from our office and see that dome building, happy to have you go talk to those folks, as we spend a lot of time trying to get that message across, and it happens in fits and starts, but we're talking about something pretty significant.
Yeah, and I would really echo what you said about people who don't perceive themselves as being poor, and so when we call people something that they don't identify with, we've kind of lost them. At the same time, we do look at various socioeconomic indicators. I think it's interesting that you mentioned that. I've never thought about literally staying away from the word poverty, but I probably do for the reasons that Linda pointed out.
So have a nice round of applause for the panel again.
You guys are great.